So for those who are new here, my name is Mary. I'm the health educator in our organisation. So I always run the webinars. You'll see my face in these sessions from time and time again. Today we are talking about understanding rheumatoid arthritis. I understand a lot of us who are here today live with this disease, and so this is a general guide to diagnosis and management. So whether you've just newly been diagnosed and you've recently received your diagnosis and you want to know a little bit more about early management and effective management, this is a session for you. If you've been living with this condition for 10, 20 years, I hope this session still is able to help you in understanding how you can effectively manage your symptoms to live your best quality life.
Okay.
So
I
will take all your questions at the very end of the session. If anything comes to mind that you want to ask, I will ask everyone to kindly just pop them into the chat box. You can see that chat box at the bottom of your screen. If you click in there and type your questions, I will circle straight back to them at the very end. So we will be talking a little bit about what the disease actually is so we can better understand what kind of condition we're living with. We'll talk a little bit about those risk factors in terms of occurrence and risk factors that can make management a little bit more challenging. Talk about the diagnostic process, signs, symptoms, medications, and some of those non-pharmacological self-management strategies that can help better manage the disease. I will start with a disclaimer that the presentation today does contain very general information and advice. We've gone through every effort to make sure the information we provide you is accurate and reliable, and it's not a substitute for the individual treatment advice of your doctor or health professional. And if you do have any questions that relate to your individual treatment, I will always direct you straight to your main healthcare provider or your rheumatologist. I do want to acknowledge the traditional custodians of the land in which we gather today. We pay our respects to their elders, past and present, and recognise their continuing connection to land, waters, and culture. I will start with opening the floor very briefly. What do you know about rheumatoid arthritis? One or two words to put it simply. Anyone want to jump in?
Yeah, autoimmune disease.
We know it's autoimmune. Absolutely. It's debilitating. Yes, I'm sure a lot of us here can agree with that.
It can cause osteoarthritis as well.
Can cause osteoarthritis due to its inflammatory nature.
It's quite painful.
And painful.
And causes fatigue too.
And it takes your energy away.
Yeah.
Mornings are hard to start. And then of an evening, I go to bed at 8:30. I am that worn out and I've done nothing all day. I've had it for 18 years. So, I'll try to get my camera right.
That's absolutely fine, but something a lot of us can relate to, and I'm sure a lot of you share very common experiences there. So let's start with talking about what this disease actually is, starting with, generally speaking, to arthritis. So known as a condition to cause a lot of joint pain, stiffness, swelling, a decrease in joint mobility. So we obviously have two different types. We have inflammatory and non-inflammatory types. The two that most commonly afflict us, osteoarthritis and rheumatoid arthritis. And admittedly, osteoarthritis gets a lot of attention, which can sometimes lead to rheumatoid arthritis being overlooked, despite how severe and debilitating this disease actually is. So today we are bringing it into the limelight. Each case of rheumatoid arthritis is very unique. The pain is not measurable. It's not consistent. And It's not visible either. It's what we know to be an invisible disease. So it does create a lot of fear about inevitable disease progression to disability, in which we're coming to learn more about. It couldn't be further from the truth. While there is no cure for this disease, we can actually aim for remission or low disease activity, which are very positive and achievable goals for many, especially those who have just been diagnosed with this disease. There are a lot of misconceptions, education gaps, and stigma surrounding rheumatoid arthritis. So again, we say that this is an invisible illness, meaning that someone can appear to be quite healthy on the outside while simultaneously dealing with the significant pain, the fatigue, exhaustion, and a wide range of other symptoms on the inside. So this invisibility not only leads to misunderstanding of the condition, and it could be amongst your friends, family, your partner, colleagues, even healthcare providers sometimes. So it can lead to underestimating the impact it actually has on our lives. It can be incredibly isolating for many. It can change the way we see ourselves, our abilities, and even our future, if you've ever had those thoughts about where our future is going. So rheumatoid arthritis, whilst it's a form of arthritis, we said before it's an autoimmune disease, meaning it can affect more than just our joints physically and mentally. It also doesn't always lead to long-term disability if it's treated early enough and managed effectively. And so online, you will see a lot of treatment success stories if we look closely. But in some cases, I want to say it does lead to disability, and there should be some safe space for those conversations around accepting disability and reiterating that it's not the same thing as giving up. It's about preparing for and embracing the reality of living with rheumatoid arthritis that actually prioritizes your quality of life and what that means to you. So this is why we do what we do, and we educate and we challenge some of those attitudes, the misconceptions, address some of those fears, and continue to support you in your self-management. And ultimately, we circle back always to the first line of defense when we talk about living with any kind of arthritis. It's about education and understanding what this disease actually is. So what I want to take you to is this screen here that we're seeing. We're seeing a comparison between a healthy knee joint and a knee joint with rheumatoid arthritis. So starting with your healthy knee joint, I apologize if you've already heard this about the structures of a healthy knee joint, but I will go over it again for those who are new here. When we have a healthy knee joint, you have bones connected to tendons, connected to muscles. Then you have a joint capsule between the two bones, which encapsulates a fluid-filled space. At the very end of the bones, we have a surface called cartilage. Now, when we have rheumatoid arthritis, the structures that we're most interested in include the synovium. So what that is a thin membrane that lines the joint capsule, and it's when the immune system malfunctions and produces very high levels of inflammation, the normally thin synovial lining becomes thickened, and it consequently results in changes of the fluid in that space between the bones. So this is what can eventually lead to joint swelling and the capsule stretching, which is when you start to see some of those physical changes in your joints. So whilst we're showing you this process in the knee joint, it's actually a process that affects a lot more joints in the body. We're talking about the hands, the feet, the ankles, elbows, hips, and more. Just continue letting some people in the room. So rheumatoid arthritis, it affects the body on multiple levels. It does ultimately begin with autoimmune dysfunction, meaning that the immune system has a really hard time distinguishing between harmful invaders, and this could be bacteria, viruses, pathogens, and healthy cells and tissues. So the immune system mistakenly attacks healthy joint tissues, particularly in the synovium, that thin lining surrounding the joints. So the immune dysfunction is what ultimately leads to chronic inflammation and plays a central role in the joint damage that can occur with rheumatoid arthritis progression. Over time, if this inflammation becomes chronic, it can sustain that joint destruction, lead to misalignment of the joints, which is one of the more noticeable aspects of rheumatoid arthritis. So this is when it can eventuate into reduced functionality and overall difficulty with just everyday activities. It could be gripping objects, opening the jar of pickles, walking down the street, climbing the stairs, doing your groceries. So there's a number of ways this can create a lot of challenges in our life. And again, while it primarily affects the joints, it's not just a joint disease. It can impact our other organs like the heart, the lungs, skins, the eyes, blood vessels. So this is what we know as extra-articular effects if the inflammation isn't controlled. So this is why we have a lot of focus on controlling disease activity when you are talking with your doctor. It can increase the risk of comorbidities like cardiovascular disease and lung disease. And again, it highlights why monitoring is really important in this condition. We don't really know what causes it, but research does suggest it can result from a combination of genetic, immune system, environmental, and lifestyle factors that trigger the disease in susceptible individuals. So we don't think it's directly inherited, but genetics certainly plays a role in likelihood of developing this condition, especially when it's combined with other things like smoking, infections, environmental toxins. Some people are more vulnerable to hormonal fluctuations that we see in pregnancy or menopause, even gum disease. So how I always compare it, it's like almost like a loaded gun where your genes are the loaded gun and your lifestyle can sometimes pull the trigger. When we talk about risk factors, we talk about separating them into things we can control and things we can't control. So they're known as modifiable, things we can control, and non-modifiable, things outside. So smoking is one of those number one modifiable risk factors. So if we haven't quit smoking, I hope that is a conversation we're willing to have after this session with the GP. It's known to place large amounts of stress on the immune system. It's up to 3 times more common in smokers than non-smokers. But not only does it increase that risk in occurrence, it can actually mitigate the benefits of treatment. So it can reduce the effectiveness of a number of different medications, but particularly those anti-TNF medications. Gum disease is another one, an advanced stage gum disease. If earlier stages aren't treated, so those bleeding gums, redness, swelling of the gums, we don't know exactly how they correlate with one another, but we do know there is a link there. And so oral hygiene should absolutely be monitored and screened. And there are lots of questions about diet, which I'm going to circle back to. Diet, weight, and stress in particular, where they fit into the risk category. So we can't really confirm at this stage whether they directly cause rheumatoid arthritis, but we do know that certain lifestyle habits, particularly poor diet, being overweight or obese, and enduring chronic stress can certainly worsen symptoms. It can feed into disease progression and sustain chronic inflammation in the body. So we'll circle back to that shortly when we address that. The symptoms of rheumatoid arthritis are typically distinguishable, can include and often includes joint pain, swelling, stiffness. It's in rheumatoid arthritis where it's the smaller joints that are often affected first, your fingers, your wrists, and your toes. But there's a key points of difference between RA and osteoarthritis is that there is a symmetrical joint involvement, meaning that rheumatoid arthritis usually affects joints in a bilateral pattern, meaning that both wrists, both knees, elbows, thumbs are simultaneously affected. And so this symmetry is a key feature of the disease. Affected joints can also become very visibly swollen, red. They can feel warm to the touch due to increased blood flow. And as the disease progresses, the joints can lose their flexibility. It can be harder to move then, hence why it becomes harder to engage in daily activities. And some people with rheumatoid arthritis can develop those firm lumps under the skin, known as rheumatoid nodules, and often around the pressure points like elbows or fingers. So beyond the joints, there is fatigue and malaise. So exhaustion, brain fog, those general feelings of being unwell, especially during flare-ups. Occasionally fever, weight loss, or dryness in the eyes and mouth can arise. And when you present to the doctor, there is, for the most part, a lot of focus on the disease and purely through a medical lens, meaning that there is a lot of focus on your lab results, assessment of joint damage, and medications to treat the disease activity. So the joint swelling, stiffness, and pain are certainly acknowledged, but it's also really important, and I want to remind everyone that it's about being transparent in how the symptoms are affecting you emotionally, how they could be causing you to lose sleep, how the fatigue is more than just tiredness, how it's absolutely gets you to a point of exhaustion and creates increased difficulty with everyday tasks that you were not once able to do normally. So this condition is what it should be treated with what we call a person-centered approach. So reducing activity and ideally achieving low disease activity or remission is a primary medical goal, but you're ultimately the one who's living with this chronic disease. So despite inflammation markers, whether they appear controlled in your lab tests or not controlled, it's equally important to consider the impact these other symptoms are going to be having on you and those functional limitations. So it's really important that when you're talking about treatment, it's being adjusted to align with your goals, whether that's you wanting to just be able to walk the dog in your neighborhood or be able to go back to work and take less sick days, or care for your family. So many of the symptoms I mentioned are just before not externally visible, and they can often lead to others underestimating the impact, which can feel isolating. The internal conflict between what you're actually experiencing and how others perceive you can be really challenging to navigate. So rheumatoid arthritis, it doesn't just affect the body, it takes a significant toll on mental health, self-identity, and emotional well-being. And this aspect is really important to address. RA has a very unpredictable nature. It can cause a lot of constant worrying and frustration and lead to a shift in self-perception, leaving you questioning your abilities and your independence. So this loss of physical function is one thing, but it can also affect your relationships, your work, and your social life. And this is what, especially when others don't fully understand the disease. It's not uncommon for co-workers and employers to underestimate how deeply RA can affect just your physical self, but also emotional aspects of your life. And, you know, people can often see you going through those motions at work or in the household without recognizing the underlying pain, fatigue, and the other challenges that come with it. So that lack of understanding makes it really difficult to fully communicate the toll it's having. And it can maybe cause you to feel that pressure to keep working without support or accommodations that are necessary, which can lead to worsening symptoms. And this is where we talk about a catch-22, because we know pain and fatigue increases stress, stress increases inflammation, inflammation triggers a flare-up, the more flare-ups you endure, the more it's going to increase pain and fatigue. So it's really frustrating because symptoms feed the disease and the disease feeds the symptoms. So it's really important that we're exploring strategies to break these kind of cycles. And then you have another layer where you're looking at the financial burden of healthcare costs, cost of medication, loss of income, cost of appointments, and more. And so we will have a separate session when we actually talk about things like understanding these financial aspects, navigating them, and understanding even your rights under the law, which can protect you and allow you to have those workplace accommodations. So moving forward to diagnosis, initially to obtain one, your primary care doctor or GP is the first point of contact who will provide you with a referral letter to a rheumatologist. I'm sure if most of us here have rheumatoid arthritis, we're under the care of one or you're on a wait list to see one. That appointment will typically include a summary, or that referral letter will include a summary of your symptoms, test results, and any treatments you've tried. It's the rheumatologist who will go through a very detailed medical and clinical history of symptoms. They will perform a physical exam on your joints, which is called a joint count, and confirm your diagnosis through advanced blood work, measuring anti-inflammatory markers, your antibodies like rheumatoid factor, anti-CCP antibodies, ESR, and C-reactive protein. For those who are very new to this, rheumatoid factor is useful to help diagnosis. About 75% of cases have a positive rheumatoid factor, but it's not the end all because other chronic diseases might also show up with a positive rheumatoid factor. Anti-CCP antibodies, this is more specific. So their presence is actually a key marker for rheumatoid arthritis and helps in diagnosing the disease, often before physical symptoms appear to worsen. Positive anti-CCP tests with high levels can also be an indicator of a more severe or progressed form of the disease due to its specific nature. But what I want to highlight is that not everyone with rheumatoid arthritis will have positive levels of rheumatoid factor or anti-CCP. So some people are known as a seronegative type. And it makes it challenging because it means you and your doctor should rely on other assessments to monitor how your RA is progressing. Your ESR and CRP in your blood work are they're very common inflammatory markers, frequently monitored to continually check levels of inflammation in the body, assess disease activity. So these will be frequently monitored in future appointments with your rheumatologist. But it's also your symptoms that are equally important to monitor and address. So before, when I said, doctors can look at your symptoms with a very medical lens, and whilst the focus is mostly on disease activity, the biological markers of inflammation don't always necessarily correlate with your severity of symptoms or pain. So, it's important that we're actually describing what you're feeling, how it's impacting on your quality of life, if you're going to be making shared decision-making decisions in your treatment. So a complete blood test is also used to check for things like anemia, which is a common deficiency in people with RA due to chronic inflammation. But in addition to the bloods, a physical exam will consist of feeling all the joints in the hands, the wrists, the elbows. Sometimes they might be very painful and swollen. Other times they might not be very painful and slightly swollen. So your rheumatologist might order x-rays, MRIs, or ultrasound to see if any damage has already happened or where your joints are at. And they will assess if there's any other medical conditions to flag or monitor closely if it's associated with RA, and if there's medications that might contraindicate any treatment for RA. So the challenges we have with diagnosis and monitoring your disease is those appointments with a rheumatologist. Depending on your location, getting an appointment with a rheumatologist can take some time as they often have longer waiting lists. And we do see this in rural and regional areas quite a lot. So there are a few options. Sometimes you can ask your GP if your case can be considered urgent or expedited due to severity of symptoms. Another option is to explore seeing a private rheumatologist. Sometimes wait times can be slightly shorter, but on saying that, they can be more costly as well, which is not always accessible to everyone. There are telehealth services that are now available. Some rheumatologists will offer virtual consultations, which can be explored to reduce that waiting time between appointments. So, rheumatoid arthritis is progressive. It means that it can get worse over time without the treatment. So, data indicates the damage can occur quickly. The sooner the treatment has commenced, the better the outcomes are going to be in terms of actually preventing any long-term damage and preserving that function. So in an initial treatment plan, DMARDs, disease-modifying anti-rheumatic drugs, are typically that first line of defense. The most commonly prescribed one is called methotrexate, which I'm sure some of us or most of us have been on at some point. It's often combined with folic acid to reduce side effects. Now, in newly diagnosed individuals, there is a lot of stigma around methotrexate. Often it's because it's associated with chemotherapy. As soon as you jump on Google, seeing its use in cancer treatment is one of the first things that actually pops up. And that can be very scary to read, but it is also worth mentioning that it's one of the most well-researched and effective disease-modifying anti-rheumatic drugs on the market, playing a key role in preventing joint damage. And it's actually used at much, much lower doses than in cancer care. So to see any kind of noticeable effects take place from using this medication can take anywhere from 4 to 6, 12 weeks. Sometimes in some cases, it can take up to months to see noticeable effects. So it's really important to be patient during this time and continue following your treatment plan as prescribed. There are actually many other options on the market, and which one is going to be most appropriate for you depends on your individual case. So medication, again, is really important for addressing the underlying immune dysfunction, halting the inflammation and preventing any kind of damage in your joints. But it's not going to have an immediate effect on pain, which is something that should be addressed separately. So what everyone should ideally be getting in care is education, not just about the disease, but about a safe and appropriate, consistent medication use. And then we have the self-management component as well to complement our medication. So ideally, the promotion of physical activity, therapeutic exercise, healthy weight management, and mental health support. So management of arthritis is always going to be most effective with a multidisciplinary approach. And so your healthcare team are there to support you. So although the medication, apologies,
It's all right.
cough for just a sec. Throat has dried out. Has anyone got questions while I catch my breath?
I've had, my name.
So medication will not cure rheumatoid arthritis. I think it's important to be really clear about that. Disease-modifying anti-rheumatic drugs and biologics can be very effective for ongoing disease management, slowing that disease progression, but it should be combined with appropriate pain management and lifestyle strategies. So going back, your first line of treatment it is all-encompassing of your non-biologic DMARDs, so especially that methotrexate, which is usually tried first. If you haven't received education on this disease, this class of medications work by interfering with an immune system at a cellular level. They suppress the overreactive immune response that causes inflammation in RA, but they affect the entire immune system, not just those specific molecules that are contributing to that disease. So whilst there is broad suppression and that can overall help halt that inflammation in the body, they can have a number of side effects which can make you feel more fatigued. They can play into mental health. They can absolutely make you more prone to infections and lead to side effects on the liver and gut as well. So their safety profile should always be discussed with your doctor. Everyone reacts differently to medications, but I will reiterate that it is a well-established treatment with a strong track record, which is why it's usually that first line of defense when you first get diagnosed. Non-biologic DMARDs, if they fail, after 3 to 6 months, your rheumatologist might look at the next class of medications, which are called biologics. So these will be trialed. They're drugs that target the specific molecules in the immune system rather than just suppressing your whole immune system. It makes them a more focused treatment. So it could potentially cause fewer side effects. So if those side effects are affecting your quality of life, it's important to actually bring this up with the doctor, and I'll go back over this. But sometimes both of these types of medication are actually used together for better disease control, depending on what the disease activity is doing. So if you've been prescribed a certain medication and you're reacting in a way that you're not sure is appropriate, it's really important to be proactive in discussing concerns and preferences with your healthcare provider, remembering that it's more than just what is happening at a biological level and what's going on in terms of your disease activity. It's about your symptom and your quality of life. So you're well and truly in your rights to request adjustments if you think it could be necessary. The more specific and detailed you are with your provider, in how you hope the treatment will impact your daily function, the better control over your disease you're going to have. So the reason I bring this up is that there was some research that was done not very long ago where 249 patients living with rheumatoid arthritis, 70% of those had high disease activity, yet 38% were offered a treatment change at their last appointment. Amongst those who had persistently high disease activity for 12 months and more, only 39% of those were offered a change in treatment. So what this is telling us or suggesting is that people aren't always getting adjustments to the medications, even if your symptoms are remaining severe. So if you're someone who is struggling with your symptoms, you've been on the same medication for over 12 months, you haven't noticed it making a difference, you're definitely in your rights to bring that up to your doctor to talk about your goals in terms of treatment. While it's important to control disease activity, it's about making sure you feel as healthy and functional as possible, which can sometimes be overlooked in that clinical setting. Again, your goals, whether it's reducing pain or improving mobility, it could also mean you just want to be able to carry your own groceries or do your own housework. So having that ongoing open dialogue with your doctor is very important. So when you're starting out with your disease-modifying anti-rheumatic drugs or during your flares, additional medications may be used to manage symptoms. So these might look like glucocorticoids, corticosteroids, non-steroidal anti-inflammatory drugs or analgesics such as paracetamol or osteopanadol. These are generally used as a part of the broader treatment plan to provide you with that acute pain relief if it means it's going to get you to the shops or get you to that social event you really want to go to. We do want to say that opioids are not actually a first-line treatment for rheumatoid arthritis and are generally not recommended for long-term pain management, including oxycodone, endone, codeine, or any variant. While they can provide short-term pain relief, and it may have its place for you depending on where you're at in your journey, the benefit is often negligible beyond very temporary pain relief, as they can cause significant harm. So we know in the context of people who take regular opioids, they're going to be at greater risk of drowsiness, falls, fractures, addiction potential, and unwanted side effects. So we have a lot of research now that shows they're not effective long term, with only helping induce a 30% reduction in pain, which is not much. And after a short while, the risk for developing a tolerance to opioids increases exponentially. So what that means is that to get that same amount of pain relief that you were once able to achieve by taking this drug, a higher dosage would be required. So this is how we start seeing it feed into a cycle of addiction. And not only that, it can actually lead to a higher pain experience. So opioid-induced hyperalgesia, which is basically a change in the nervous system that causes hypersensitivity to pain signals. So in some instances, they're absolutely going to be required, particularly for severe pain during acute flares, if your doctor has discussed this might be appropriate for you, or post-surgical recovery. Or in some instances, it might be for people who can't tolerate the other class of acute pain relief. But it's really important that you're talking with your doctor about safe use if that has been discussed. So we know rheumatoid arthritis is a very chronic, fluctuating condition. So we have periods of increased symptoms and increased disease activity. So we have periods of flares and periods of remissions. Flares can be triggered by a number of different things. Stress, whether it's emotional or physical, is one of those leading triggers. It could be infections like the Epstein-Barr virus, or illness, overexertion, even changes in medication. Sometimes it just happens randomly and we don't know what has triggered it. Flare-ups don't mean the treatment you've been taking is ineffective by any means, but they are a natural part of rheumatoid arthritis and can happen even if the disease is being managed well. If the flare-ups are becoming frequent or severe, then this is your sign to open the dialogue with your doctor about adjusting the treatment plan, and it's to better manage those symptoms. So managing flares, it does require that multifaceted approach beyond the GP and rheumatologist. It could involve adjusting medications, but sometimes it could just involve increasing rest, looking at pacing strategies, bringing in gentle movement under the supervision of a physio, and using acute pain relief where it's needed. So even heat, cold therapy, topical creams, and stress and mental health management. So under working with a psychologist or a counselor to address any underlying emotional or mental stress. Remission is one of those key goals in treatment. It occurs when RA symptoms subside significantly or disappear, and the inflammation is minimal. If remission isn't fully achieved, then low disease activity is the next best goal to have, which just means fewer symptoms, reduced inflammation, minimal progression of joint damage, but better quality of life. So when rheumatoid arthritis is in remission, or low disease activity, we get a lot of questions about whether you can reduce or stop medication. That often arises, and it's very natural to wonder that if you've been without any symptoms for X amount of time. Now, if your remission is stable for at least 6 to 12 months, where there has been little or no difference in your symptom severity, duration, physical function, you've had no serious side effects, your rheumatologist might consider reducing that dose of medication gradually. They might consider spacing it out, spacing out the injections or infusions over time, but also ongoing monitoring for any early signs of disease activity returning. So it is possible for some people to achieve this under medical supervision, of course, but it's really important to do this carefully and closely with your doctor to avoid triggering a flare or a setback. So the reality of this condition is that remission might not last indefinitely, but it can absolutely be maintained for as long as possible. So if you've heard of a flare plan, these flares can be very unpredictable, but a flare plan might be one of those tools which help you act quickly, reduce its impact, and prevent it from lasting longer or worsening. So it's ultimately a proactive strategy developed in collaboration with the healthcare team, physios, exercise physiologists, rheumatologists, GPs, OTs, which focuses on early intervention and symptom management. So a typical flare plan might include identifying early signs of a flare. So whether that pain has increased just a little bit, swelling has come back, fatigue is increasing or worsening, medication adjustments, knowing when to use your prescribed medications, and pain relief medications. So NSAIDs, corticosteroids are pain relievers. Rest and self-care is a big part of the flare plan. So rest should absolutely be encouraged. You should look at modifying activities and using those heat or cold therapies for relief, but also having a symptom tracker. So making sure that you keep track of your symptoms, knowing when to reach out to your doctor, especially if they worsen or don't improve after 6 days. Reducing stress and focusing on self-care can include eating well, staying hydrated, and pacing strategies. So pacing is really important for managing energy and avoiding overexertion. And it might include breaking tasks into smaller steps. If you've woken up one day and you're having a flare, it could actually be asking yourself, what do you really need to do today? What do I need to prioritize? And practicing this with self-compassion. When you're dealing with the challenges of RA, it's reminding yourself that you're doing your very best and things might not go as planned from what you anticipated. So exercise will make my joints worse. I should rest and avoid activity during a flare. Exercise will increase pain and cause injury are very common misconceptions, very common fears around exercise. And understandably, the thought of exercise and moving can be scary for some with very painful joints, and especially during a flare. But what we're coming to learn more about now, and we have data to show that regular exercise can actually not only help with improving symptoms, can help with increasing function, but it can help with less severe disease and help with long-term pain relief. So it can help overall fatigue, heart health, stronger bones, improve mood and sleep, particularly those low impact exercises like walking, swimming, cycling even. When we strengthen the muscles around the joints, we can have better support on them and reduce the strain on them. So it can really help with pain long-term, inflammation, and function over time. So it is very important to rest during a flare, but gentle movement can still be very beneficial. So very light stretching or range of motion activities are going to be the best kind of activities you can do. So when we're talking about gentle activities or range of motion exercises, it could just be moving your wrists in circles, finger stretches, shoulder rolls, maybe cat-cow stretches. But having an exercise plan that fits your individual needs, symptoms, and limitations can help, especially during those severe bouts of stiffness, and prevent the stiffness from worsening. These kind of exercises are going to be good because they're not going to overload the joints as well. And of course, we want to avoid those high impact exercises, heavy lifting and overstretching or forcing movement. Questions we often will come in about diet. So addressing the diet, I will say, can't prevent causation or prevent a flare-up, but we have more and more evidence suggesting that modifying these things can lead to lower and fewer side effects from the inflammatory attack and potentially influence the course of disease. So from a weight management perspective, we know that diet can have a huge impact on weight and load. And we have lots of data that suggests carrying excess weight can absolutely worsen symptoms. So our fat cells have shown to increase the production of inflammatory substances, those which are very similar to what we see in an attack of rheumatoid arthritis. And so weight loss in someone who's currently overweight has shown to make a very meaningful difference to pain symptoms. We also know that there are foods that can either increase inflammation or reduce inflammation. We know that foods that are more processed, have higher trans fats, saturated fats, added sugars, low in fiber, have different pro-inflammatory effects in the body, which can contribute to sustaining overall inflammation. And this is due to how they affect the gut microbiome, how they affect the regulation of the immune system. And we're starting to learn more about how they affect the joints specifically. So reducing the intake of these foods could potentially have a beneficial long-term role. So you'll see many, many variations of anti-inflammatory diets. Just letting some people in. But what you'll notice is that they typically tend to be dominated by fruits, vegetables, healthy fats, legumes, and whole grains. Who's heard of the Mediterranean diet? It's one variation of this theme, especially when you add in fish and olive oil. The diet alone won't ever replace medication or other treatments. Despite people wanting to trial those alternative methods, but it can absolutely complement your overall management strategy for long-term rheumatoid arthritis management. So it can help in reducing inflammation, supporting joint health, managing weight, and improving overall well-being. A balanced diet rich in fruits, vegetables, whole grains, omega-3 fatty acids, not only helps with overall systemic inflammation in the body, but it could also help with the effectiveness of your treatments and better disease controls. So this is why we go back to the healthcare team and who should be involved in your management. And we speak about working with a dietitian for that tailored approach, as they can be beneficial from a long-term management perspective. So of course, we're an organisation that are here to help you and educate and support you in your self-management journey. We have warm water classes, dance classes, we have education and information-based services. So if you do have questions that you want to ask in regards to your management, the Arthritis Movement are here. You can find more information on these services on our website. But overall, there's really good evidence to back the treat to target approach. So for those who don't know what that is, it's basically about working very closely with your rheumatologist and your GP, setting really clear treatment goals. For the doctor's perspective, they'll usually want low disease activity or aim for remission, but it's also about your quality of life and functioning. It's about making regular adjustments to your medications based on disease progression, but also assessing symptoms. So medications might need frequent changes, which can be frustrating if side effects occur, but sticking to your treatment plan is going to be really important. If your symptoms are improving, it can be tempting to cease medication, but it should never be done without a thorough conversation with your rheumatologist. Not everyone responds to the same way to treatment. So this process of finding the right treatment for you, it requires a lot of trial and error, but being really open and transparent with them. So always stay informed about your disease, your treatment options, communicate clearly with your rheumatologist, and ask about treatment adjustments. Support networks are essential for your treatment and long-term management. So communicating openly with your family, friends, co-workers is absolutely essential. It's about setting clear boundaries, especially if we're trying to break that catch-22 cycle that can occur with symptoms feeding into the disease and the disease feeding into your symptoms. And of course, there are healthcare barriers that can afflict most of us in different ways. So if, you're experiencing the financial burden of having this disease, make sure you're talking to your GP about your options and the pharmaceutical benefit scheme, how that could benefit you, or you're exploring what private health can do for you in terms of manage specialist appointments and treatment. So what I'm going to do is open the floor to some questions.